That brings us to the next part of our presentation, and women with ovarian cancer being misdiagnosed, sometimes more than once, unfortunately is all too frequent. For women and their families, it is simply devastating. Without a reliable screening method and vague symptoms, there is no simple or quick solution to overcome these challenges. Survivors Teaching Students is an ANZGOG program and an international initiative where women educate medical students about their own cancer diagnosis, or commonly, their misdiagnosis journey. Our next speaker is Dr Helen Gooden, who has specialised in psychosocial support for patients in ovarian, pancreatic, brain and cancer of the unknown. She has a particular interest in health communications and consumer involvement in education and research. And that pretty much makes her perfect for her role as ANZGOG's Survivors Teaching Students National Co-ordinator. Please welcome to the stage Dr Helen Gooden, and I'd also ask Kristen Young, one of our Survivors Teaching students, to join her on stage. Thank you so much.
Thank you very much for the opportunity to come along and talk to you this afternoon. And I just want to welcome you from far and wide, because I know quite a lot of you have travelled from far and wide to come here today. And I'd like to also welcome our people that are watching virtually online. So we've had people today who've come from as far away as Western Australia, from country New South Wales, from in and around Sydney. Have we got any Victorians in the audience? We did have earlier. Yes, we do. So I want to thank you and welcome you today. So Survivors Teaching Students, this is a fantastic program, and I'm very proud to be the coordinator and launching this program around Australia. And I feel very privileged to work with all the amazing people that I do work with, women and caregivers, both male and female, that have been affected by ovarian cancer. And we have quite a number of those with us here today. As part of our annual scientific meeting, we've had a meeting with all of our coordinators from around Australia, and this has been their first opportunity to get together, and it's been a wonderful opportunity, and we've really enjoyed meeting each other and having that opportunity to talk and collaborate together. So Survivors Teaching Students, it's an innovative volunteer-led education and awareness program. It was started in the US by an organisation called Ovarian Cancer Research Alliance in 2002, and it was started by a woman whose name was Betty, and she herself had a difficult pathway to diagnosis. And she thought about this, and she thought, where can I make the biggest difference for the future? And she also believed in the power of one woman to make a difference. So she thought that working with medical students and our health professionals of the future, our future diagnosticians, was going to be a really powerful way to make a difference for the future. And as Professor Beale said earlier, in the absence of an early screening or early diagnosis test, this is the most powerful way that we can make a change for the future in ovarian cancer. So since 2002, the program has been taken up in the UK, in Canada, and just over 18 months ago in Australia, and we plan to be launching in New Zealand as well later in the year. There's over 1,200 volunteers worldwide working in this program, and we've reached more than 15,000 medical students, which, let's just stop and pause and think about that for a moment. That's 15,000 of our doctors of the future who now know that when a woman comes in complaining of gynae symptoms, they need to be alert, to be curious, and to investigate, and rule out ovarian cancer or other gynae cancers sooner rather than leaving that to be the last thing that may be looked at. If we can achieve an earlier and timely diagnosis, we can get women into treatment at the earliest possible time frame. The outcomes will be better. I'd also like to mention and acknowledge that this program has been able to start in Australia not only with the support of ANZGOG but with the Cancer Australia Supporting People with Cancer Grant Initiative. And with Cancer Australia support, that's allowed us to establish the program over the next 3 years, and we will be taking the program forward. So what are our learning goals? So it's all about the power of your story. We say to our students that this is a volunteer program, but every single one of our presenters have a PhD. They have a personal history of their disease and they're experts in their own experience. And your experience is extremely powerful to share with the students. The students have really responded extremely well to your stories, and they understand the importance now of listening to you. They understand the signs and symptoms of ovarian cancer that they need to be alert to. And the fact that we have 3 presenters talk in each of our presentation demonstrates to the students the diversity of the disease and how it can present in a number of different ways, and it is and across a number of different ages. And as you can see, a very important part of our message is the importance of communication in health and in a diagnosis of ovarian cancer, and how good communication with you and your family can make a real difference to your experience of ovarian cancer through your treatment. And you can see that our students really, from the feedback that we get from them, because we evaluate the students before and after your presentations, we evaluate them for a baseline understanding of ovarian cancer, and then afterwards we look again at their understanding of ovarian cancer and the shift in knowledge as a result of your presentations. And we also ask them some extra questions where they give us qualitative open feedback about the impact of hearing your stories and the lessons that they've learned that they want to take forward in their future practice. And as you can see here, it was valuable to hear from women and families directly about what we can do in our clinical practice to provide the best possible care to our future patients, no matter what specialty we are in. And that's a really important part of the program and why we deliver it to medical students, because it doesn't matter what specialty they end up going out and doing. It's quite likely or possible that they may come across a woman who has gynae symptoms, and having had an understanding from hearing your stories and the power of your stories, it actually sticks in their brains much more than reading it out of a textbook. And the other thing is that our students have been really impacted strongly and positively by the stories of caregivers, because caregivers are quite invisible in our health system. They're not in the textbooks, and giving our students, our medical professionals of the future, an understanding of how important the role of the caregiver is in your care, in your outcomes, and looking after you, and also looking after themselves. And it also helps them understand the ripple effect of a diagnosis of ovarian cancer or any cancer on the whole family. It's not just the person that's diagnosed. So what do? We share our stories. And this is Kristen, who we have with us today from Brisbane, sharing her story. You're in a unique position to help our students to become more sensitive to the signs and symptoms of ovarian cancer, so that when they go into practice in the future, they have the opportunity and the understanding to potentially diagnose you sooner. And what do? You go into the classrooms of medical, nursing and allied health professional students in generally where you live, although at times we do a little bit of travelling, where you live, and you just share your stories. You do not have to have any sort of public speaking qualifications at all. The most important thing that you need to do to be able to do this program is actually just be yourself. Is just go in and be yourself and talk. Because as doctors of the future, they don't mandate who's going to walk in the door or how professional they're going to present to them or how together they're going to present to them. It's whoever comes. And that's exactly the qualifications that all you need to be part of this program is just to be yourself. So the forums that we present in, it can sometimes be a small tutorial group like this, and they're generally students in their 3rd or 4th year, or it can sometimes be 2nd year medical students or nursing students in a bigger forum. Our survivors and presenters who are here today, and Kristen will attest to you, that it actually doesn't make a lot of difference whether you're speaking to a large group or a small group, because our students are really respectful of you, and they're very grateful for you coming and sharing your stories, and they're very respectful and interested, and they genuinely want to know what they can do in their future practice that will be the best thing that they can do. So how does it work? So I work with the Ovarian Cancer Research Alliance, which is the US organisation that started this program, and they've licensed it to us at ANZGOG free of charge, which means that we can use all of their training material so that we don't replicate costs. And I also work with our ANZGOG board, who are very large supporters of this program. And so what I do is I work with the universities, and I establish an interest in with the universities, and if they see where they would like to include the program into their curriculum. And the program is of a 1-hour format, and it's designed to fit neatly into curriculums, but it doesn't have to. It can be presented as extracurricular or forums as well. But to date, all of our 11 university programs around Australia have integrated into their curriculum, and that shows how much they value the program. So once I've established that relationship with the university, I hand it over to our regional coordinator. So in each city where we're working, we have a regional coordinator, and here with me today, they can wave their hands if they would like. We have the Sydney Regional Coordinator, Brisbane Regional Coordinator, and the Townsville Regional Coordinator, where we're shortly going to be working with James Cook University. And we also had earlier with us our Western Australian coordinator, our coordinator from Victoria, and our coordinators from the Hunter and New England district. So the regional coordinator is the liaison point between me and the universities and their team. So the team on the ground consists of a facilitator. The facilitator both runs the presentations at the universities and also looks after her team of presenters. And when we have a date allocated, the facilitator will get in touch with 3 of our presenters and see who is available to come along and speak on that day. We'll let you know all of the details, and we'll mentor and support you on that day as well. We always have 3 presenters in our presentations to give the understanding of the breadth of the disease, that ovarian cancer is not just one disease. It can affect different ages, different ranges, and different stages. We also have the support of Ovarian Cancer Australia, who promote survivors teaching students through their wide network and reach for women to help us with our recruitment. We're always looking for new people who are interested in coming along, because our golden rule in being involved in the program is that life comes first, and we want to have enough volunteers in the program so that you have the opportunity to say yes or no to an upcoming presentation, and that you're free to go and do whatever you want to or need to do in your life without the program interfering, but you've got the opportunity to be involved. So in our first year, we have expanded the program and developed the program all around Australia. In fact, our 3-year project plan was to eventually get to 4 states in Australia in the first 3 years. But in the first year, we've in fact now we have programs running in all of our 3 initial target states, which are Queensland, Victoria, New South Wales, and Western Australia. We have interest from the other states as well, and we are just limited by our capacity and funding streams to work in those states. But we have interest from Flinders University to work in Adelaide. We've got volunteers that have already signed up in Adelaide. We've got interest from the Australian Catholic universities to work around Australia, Notre Dame to work in Australia as well, and Griffith University in their campuses, which are both on the Gold Coast and in Brisbane. And we're shortly going to be looking at starting a program in Townsville with James Cook University. And in fact, we've got our first presentation with University of Queensland this Monday. And only last week, I trained 9 women in Brisbane who are really keen and excited to be able to be starting to present in the program. So these are some of our wonderful volunteers, and I've said that there's 60 plus volunteers because that number is never static. It changes every day, and in fact even changed today. So we had a constant flow of inquiries, and we contact each and every one of you, and it's in your own time when you're ready to participate in the program. There is absolutely no pressure on you at all. We look forward to working with each and every one of you should you be interested. The age range of our volunteers is from 25 through to late 70s, and we have both men and women caregivers working in our program. So this is Michelle in Melbourne doing her thing, presenting to Year 2 students. When Michelle came along, she said, "I'm not really a public speaker, I'm not really sure about this," and I reassured her that you actually just be yourself, go in and be yourself. And she actually found that she actually was a good public speaker, and she goes out there and she does her thing, you know. And the students really respond very well to Michelle just being herself, and that's what each and every one of you need to be. So as I said, it's designed to fit into the curriculum. We have a mixture of presenters, and very importantly, we always have 15 to 20 minutes of question time. And that's where the gold really happens. And the students are really interested, and they ask the questions that they don't often get the opportunity to ask in the clinical setting. You are at no time are you expected to answer medical questions, because that's not why we're there. And also, if you feel uncomfortable answering any question, you can just simply say, "I feel uncomfortable answering that question." But to date, I don't think we've ever had a question knocked back. Facilitators? Nope, no, not to date. Yeah. As I said before, we evaluate the students before and afterwards, and we have also asked you to do evaluations with us too, because you are a very important 50% part of this program, and we need to know your feedback on how you're finding working in the program. And although there are program guidelines, there is tweaking that we do in response to your feedback to make our program as good as it can possibly be. From our evaluations of our first year, we've been able to see that our medical and nursing students are responding to the program, and that their increase in knowledge has been 23% across our medical cohort of students, and our nursing and allied health students have been from 32% in nursing through to 70% in the emergency medicine students. We pool our data with the international data set. So all of our data goes across to the US, and at the end of each year they do a comparative analysis with how we're tracking in Australia with the US, Canadian and UK programs to make sure that our message is on track and there's consistency across the messaging that we're delivering. In our first year, we've reached now more than 1,000 students, and that is well in over and above what we had expected. But it just demonstrates how interested the universities are in this program and how much they value it. Here are some of the students' responses, so it just gives you an idea of how well they respond and that they really understand the messaging. So just to read a few of them, that it takes it out of the theoretical and into the human, which is sort of the real reason we do medicine. And that's actually really important, because the students get really bogged down, and they're so bogged down in all of the learning that they've got to do that they can sometimes feel very separated and divorced from the people, which is the real reason that they set out to do medicine in the first place. So this is what is really the crux of this program. It's bringing the human element, it's bringing your stories and the faces and voices of your stories into the classroom, which is an extremely powerful way of learning. For you as survivors, as I said, we ask you to give us feedback on how you're finding the program, and some of the themes that have come through from your feedback to us is that it gives you a sense of regaining control of your life, a sense of purpose and validation, and that it gives you hope and feelings of empowerment in being part of the program. And a part of that, as Kristen will probably tell you, is the immediate feedback that you get from the students and how well they respond to your stories and you coming along and giving of your time and of yourself. We always ask you to allow at least half an hour after your presentations, both to debrief and talk to us, but also because mostly the students swarm out after you and they still want to talk to you and they want to thank you, and they're often known to hug because they're so grateful for your generosity in coming along and sharing of yourself and your story for their benefit and for the benefit of the women in the future. So the keys to the success that we have found is a good engagement with the universities across Australia, and we've certainly had that, and we've now got interest from New Zealand as well. And as I said, the benefits for our volunteers, and as one of our wonderful presenters said, speaking to medical students about our stories is an opportunity for us to give back for all the amazing support we have received over the past 3.5 years. And STS is one of the best things we do together. And that's because this particular presenter and her husband both present. And we're very grateful for the work that they do with us. They're also here. We have to talk about the hard facts of ovarian cancer to our students because it gives them an understanding of why we do this and why it's important to do this. But we don't dwell on them. And the important thing is, in you sharing your stories, is that we demonstrate that ovarian cancer is more than just facts and figures. And to demonstrate that, I'd like to introduce Kristen. Kristen is one of the original members of Survivors Teaching Students. She was one of the first people to put her hand up, and she's still a passionate advocate for ovarian cancer and for Survivors Teaching Students. She's a presenter in Sydney as well as a facilitator, and we're very thrilled that she's come along to share her story with you today. Thank you, Kristen.
So I'm Kristen Young. I'm a survivor of stage 3C ovarian cancer. So what I'm going to do is talk about STS from the volunteers' perspective. Obviously, Helen's described the program really, really well, including capturing the presenter's perspective really, really well. So I hope that does lead people to be attracted to joining it. And we're speaking also to those people out there in the virtual world who might be watching this as well. But what I might do is just do a slightly shortened version of the presentation that I do when I am presenting, so those of you who are watching can get a little taster of what an STS presentation looks like. We haven't got enough time for me to do it in full, but it's also a way of hearing my story as well. So I was diagnosed in 2009 at the age of 47. I was a busy professional person. I had no particular health problems other than those that come from just living too stressful a life. But what I first noticed was some large swollen lymph nodes in my groin. And I couldn't work out where that was coming from because I didn't appear to have any infections in my legs or anything like that. So I just really didn't do anything about that. But as the months went on, I began to get some more gynecological symptoms, some mid-cycle bleeding, which I didn't thought, well, maybe I'm 47, I can put that down to, menopause or something like that. But I did think I should ask my GP about it, and I have absolute trust in my GP, and I still do. And I said, could there be some connection between lymph nodes in my groin and me having unusual symptoms of gynecological nature? She said, no way could they be connected. And I thought, hang on, they're all in the same, geographical area, so surely, but no, that was her feeling. But as a good GP, she sent me off for a transvaginal ultrasound, which is one of the recommended actions that a GP should do when someone is complaining of these symptoms. And that came back with no evidence of any cancer or anything unusual except a few uterine fibroids, which is to be expected. But months went on, and I had another doctor I was seeing for an unrelated thing. They said, you shouldn't still be having 6 months later big lymph nodes like that, so I'll send you off for a biopsy. Went to see this general surgeon about that. He wasn't too worried. Had a look at my feet, couldn't find anything wrong with them. Don't know why you've got these lymph nodes. When would you like the surgery? And I said, I'm having a holiday in a couple of months and I don't want to, I want to be able to go swimming, so can I have it after that? He said, yeah, no worries, it's no big deal, sort of thing. So nobody was really thinking cancer at this point, so I didn't have a CA125. So I had my holiday, and came back and did the little biopsy. And a few days later, I got a phone call at work. And you know how they say doctors shouldn't ring and tell you over the phone. Well, this is, of course, what he said. I know I shouldn't be telling you this over the phone, but I've got your results and there's a tumour. And he didn't say cancer, which was interesting. He said tumour. So I'm just saying, you know, we all react differently to these words. But he didn't know what type it was. But he said, but I've already booked you in to see a surgeon and I've booked you in for a CT. So I knew it was obviously sort of quite serious. So I ended up going to see this surgeon and he was explaining, you know, the standard procedure for the initial investigative surgery. And I remember piping up at one point and saying, don't you think I should be seeing an oncologist at some point? And of course, he was a gynecological oncologist. I'd never heard of such a thing. So he was a bit offended and said, well, I am an oncologist. It doesn't make sense to me. But the way he explained the cancer, he said, it's definitely cancer. It's probably gynecological and possibly ovarian. So I liked the fact that he was able to express that level of uncertainty to me. But then he said, all right, well, we can operate tomorrow or in my next list in 2 weeks' time. And my family, which was my mother and 2 siblings, saying, tomorrow, tomorrow, tomorrow. Because they think you got to act fast. But I wanted 2 weeks because I wanted to pack up my life, you know, get out of my job, buy nighties, you know, go on a pre-surgery road trip, all the things that you need to do. Oh, wrong way.
I think that there's the next slides. Yeah, Kristen's.
So sorry. I had, I had the very standard form of high-grade serous ovarian cancer, even though it did not present in a standard way. The lymph node presentation is not common, and I had no ascites at all, so I didn't have the bloating and the pressure that people get, which is a common symptom. So I am yet another example of a non-standard presentation, but of a very standard type. So I had the standard chemotherapy, the normal operation where they, you know, take everything out, things I'd never even heard of, like an omentum. What's an omentum? And good operation outcome, everything cleared. Chemo went all right, horrible side effects. Even though I'm quite young and healthy, I still seem to attract side effects, like, you know, they just glue to me. So I had quite a lot of pain and stuff like that, and it affected my lifestyle. But I think one of my biggest frustrations during my initial treatment was being able to get the information I wanted from my doctors. I had every confidence in them clinically, but what I wanted is more access. You know, I wanted more reassurance. But, you know, I also knew, because I'm a health professional myself, that a doctor can't be there taking every little worried call from every patient on their books. There's a picture of my family here, and you notice there isn't a father in the picture because he not so generously gave me his BRCA mutation, and himself passed away from prostate cancer in 2003. And this is an interesting story in a way too, because his sister she had died of cancer young with bilateral breast cancer, 58, and no one that was dealing with either of them, had sort of twigged to perhaps there was a family pattern here. And I think that's because back in those days they didn't have that emphasis on family histories and not much knowledge about BRCA. Had they though, our family would have been tested when Dad was sick. I would have found my BRCA mutation, then I would have been able to have had preventative surgery. However, that wasn't available to me, so I got ovarian cancer, and then that provided the opportunity for my family to all be tested, and then they were able to take whatever preventative measures were suitable to them. So being BRCA is good and bad. It's bad that you might get breast cancer, but I mean that's the least of my worries really. And I'm on a high-risk monitoring program for that, which my oncologist put me straight into. But the upside is there's treatment options, and people who've been listening today kept hearing trials for BRCA, trials for BRCA. That is the golden thing about having this. There is also the worry about whether you should have a preventative mastectomy, but I just can't face another operation. I first learned about ANZGOG at this time when I did my first clinical trial, and I wanted to be on a clinical trial not for the medication. I didn't much care about that. I wanted a clinical trial because I wanted the attention. I wanted someone to be looking after me. I wanted someone to listen to me and someone to talk to about my cancer experience. And I thought if I was on a clinical trial, they'd have to do that because I'd have to go in every 3 months or whatever it was. I still don't know, after 2 years on that drug, whether I was on placebo or not. But there you go. I lasted 4.5 years before my relapse. I thought I was going to get away with it, but I didn't. And the story gets really long from here, so that's why I'm going to wind it up. And I had a second surgery, second lot of chemo, and got into my happy space, which is a PARP inhibitor. I was desperate to get onto a PARP inhibitor. It wasn't available for first line when I was going through. It's coming on now, hopefully on the PBS sometime in the near future, I don't know. But this is the drug I wanted to be on. And 4.5 years later on this, I am still here defying statistics. The words unprecedented, uncharted waters, super responder, etc., apply here. So what do you do with a medicated life where you're not well, but you're not sick? So you try and do things that make yourself relevant. Try and make a life which is limited by the side effects of your drugs and the after effects of your cancer, but still is a high quality of life and a life of value. I get survivor guilt by my long remissions, but I've been told, and it does make sense to me, that I can be sort of a beacon of hope, even if other people can't necessarily get the remissions that I've been getting, that they can say at least somebody has benefited. At least somebody's getting something out of this research and these new drugs. So I'm quite happy to step up and be that person. So that's like what I do when I do an STS presentation, a little bit longer, a few more jokes, and I walk around a bit more. But I hope you can see that that's a fairly straightforward way of telling your story. It's a story, everybody knows their story really well. They present it in their own style. That's my style. In STS, you can present it in any style that's right for you. In fact, the greater variety of styles, the better. We don't want doctors to think that everybody is a public speaker with a flash story and a joke. We want some people to be sad. We want some people to read their story off a script. We want everybody to be themselves, 100%. So public speaking, interest and skills is a non-issue in being a presenter in STS. So this is me doing a webinar just to show that, I was pretty keen to get involved in something. Now, I've now retired from my job, but I was a psychologist. And one of the things that I did as a psychologist was I developed junior psychologists through the Army internship program. I wasn't in the Army, but that was my role, and I was awarded a significant award for a contribution to military psychology for that work. So I have a long-standing love of educating health professionals, and actually even predated my working with interns, and that's why I wanted to work with interns. So when I sort of heard there might be some sort of opportunity to work with educating medical students, I thought, that's me. That's 100% me. I'm very comfortable talking medical terms. I like making a difference at a level that not just within our immediate support community, that makes a difference reaching out and also forward into the future. I'm also fascinated with communication and how communication works and fails, particularly within safety critical environments or complex environments. And I think, medicine is one of those incredibly complicated, high-risk environments, particularly when you're going into surgery. And communication is not just a matter of people learning to be nice and supportive. They've got to be able to make fast and constantly changing decisions about how to communicate. And I thought this is something that I can bring to the world by contributing to STS, because I'm very interested in that sort of thing. So we don't sit there thinking that when we list the signs and symptoms that those students 8 years later when they come back as an oncologist are going to remember that list, But what we believe and what I believe is that those students will remember the person. And I remember that I did my psychology training in 1981. We visited a mental hospital. Back then they had mental hospitals. And a patient sat in the room in the lecture theatre and spoke about his experience with a psychotic illness and the medications. And I've never forgotten him, 1981. And this is what we hope. And I don't think every person in the room will remember us, but I'm pretty happy if the hit rate is even 10%, but I reckon it's going to be a whole lot more than that. I reckon most of the people will remember us. How am I for time? Okay. So people remember people. They remember things through people. And I mean, medical students and nursing students too have got to do a lot of memorising and rote memory to learn. So if we're going to get them to take on board a message about ovarian cancer, you've got to sell it to them in a different way. And we know which way works best. It's through real people. So when you're watching them, and I've done them to groups of say 20 in a small sort of room and lecture theatres spreading right up like that. My goal is not that every face is turned to me with rapt attention, but I'll tell you at least half of them are, especially in the smaller groups. It's well more than half. And I think they just love to hear their area being given back to them in a really interesting way. And some of the stories we tell about the misdiagnosis and the clunky communication, I think people also like to hear those stories in a way, because we don't deliver those stories in a blaming or critical way. We're quite careful in STS not to slag the doctors, even though privately we might do that amongst ourselves if we're unhappy about something. But everybody likes to hear a bit of a story about things that went wrong. And as I said, we're not expecting them to get a bunch of facts, but I think what we would really like them to go away with is a sense of curiosity. And Helen said that word curious before, and that was going to be my big word for this afternoon. She took it from me, but that's okay. All I want is curiosity out of an up and coming health professional. And the other thing I'm looking for when I train people, and I hope that the students get this too, is reflection. The ability to reflect on the things that they say when they communicate with us. They can't always get it right. A doctor is always going to be misunderstood by someone. They're always going to have a bad day where they say something a bit brusque or irritating that some patient isn't going to like. But what we want them to do is to be reflective and to think, that's how I come across. Or when I said that, the patient heard it as something completely different. And that's the thing I'd like them to remember, and I think STS does. An interesting thing is that there's a lot of people, as we know, I think the significant proportion of people in the community are touched by cancer in their own lives, and many of the students have had a cancer experience in their own lives, and some of them do come up and want to have a talk to you about that as well. That's just a thing to remember. And I also don't really think we're going to turn all the stage 3s and stage 4s into stage 1s, by looking at awareness of symptoms. But it is still worth detecting a bit early. If nothing else, we could stop a stage 3 turning into a stage 4, or stop a stage 3, someone ending up with a colostomy bag and that sort of thing. So there's definitely worth it in that respect. Another benefit is there's a benefit to me. There's a benefit to the community, because an STS presenter, facilitator, whatever, belongs to a community of other people touched by ovarian cancer. And a lot of people don't want to be in support groups because they don't want to receive support. They don't feel they need it. But everybody needs social support. Everybody needs to belong and be in a community. So STS is a really interesting way to get a community based on your giving, but you also receive by being a member of the community. And it's darn good fun too. So, as that's really all I want to say. I think that for me, the future is very uncertain. I have no idea how long this remission will last and what happens when it doesn't go on, but at least by doing something like STS, I'm taking the skills and the interests I already have and doing something useful. And it's something that, even though all the research that they've been talking about in this conference, that's progressing along, this is something that we can do hand in hand with the research. We can make a difference by changing the minds of the future doctors so their eyes are more open, they're more curious, more reflective of their own communication styles. And that may also have a benefit alongside actually the hard scientific research. So that's for me. Questions?
Questions? So we might get both of you up here to share this microphone and actually have some questions. Does anyone have any to start off?
Sorry, not used to this. Have you ever considered presenting to a small group of GPs?
Yes,
You know,
yes, we
maybe-
have, and at the Mercy Hospital in Melbourne, they have a GP education forum, and they've invited us to come along and speak to the GPs. The GPs are a very hard group to access because they're extremely busy, and it's very hard for them to take time out of their own practice because they're all like, as well as being doctors, they're in their own business. So that if they step out, there's no one else there to help them. So they're a very hard group to engage with. But through education forums and actually in Melbourne University, they've particularly asked us to present the program to the GP specialty stream. So that's doctors at the end of their training who have decided that they're going to go into general practice as their specialty and that we're going to be working with them as well. And at ANZGOG, we're looking at other opportunities where we can engage with GPs and other doctors who are out in practice. But they're opportunities that come up, and when we have the capacity, we take advantage of them. But primarily our target group are medical, nursing and allied health students.
Does anybody want to say anything?
I spoke to Helen before. I think this is an amazing program, and I'd love to be involved in it. But I think it's just, as I said, if we can save thousands of lives while waiting for the research that's ticking away in the background to get funded, be successful, and then make a clinical difference. But I feel very passionately, and I'm very excited that this is happening, and I totally echo that previous question is hopefully this can get into the GP specialty program in all the universities, because that's usually our first line of help. Yeah. Thank you.
And thank you very much for your passion and for your involvement, and we look forward to having you on board. And we're only limited by our capacity, so the more of you that jump on board, the more opportunity we've got. So thank you very much.
So more of a statement than a question, sorry. So as you both know, I'm a doctor as well as a patient. And I know the benefit of this program. My favourite subject at university was genetics. It was because the presenter would bring in patients or patients' families. So, and I would remember, I still remember Huntington's disease, really rare disease, but I know Huntington's because they brought the patients in. And so I know that, but I also know from my own friends, because I've got a lot of medical colleagues, that by sharing your story with them and being open, like one of the guys, he's a ED trainee, so he will actually come in contact with women presenting to the ED with symptoms. And he said, Alicia, since hearing your story, it's changed my practice. So like our stories, we can make a big difference, and the stories can be quite powerful.
And I just want to also mention that one of our members, who's the head of the genomics laboratory at the Collins Institute in Sydney, after hearing about the program at our ASM last year, she asked me if she could send along her bench scientist to listen to the program as well, because they're working every day with your tissue, and she felt it was really important that she actually hear from you so that they can connect the dots. And so they came along to our presentation. They continue to look for opportunities to come along, and they were really powerfully impacted by your stories, and really grateful for that opportunity. Thank you.